I welcome everyone to the lecture on acute pain. My name is Śmietańska. I'm an anesthesiologist and I work in Department Anesthesiology and Intensive Care. Today I won't say on acute pain. The first part is about assessment, and the second is about pathophysiology, and third part is about treatment. What is the pain? Have you ever felt any pain? It is I think, not easy question because pain is unpleasant sensory and emotional experience associated with actual or potential tissue damage or described in terms of such damage. It should be noted that pain is subjective and indicated that each individual learns the application of the word through experiences related to injury in early life and characterized in the experience as unpleasant and therefore emotional as well as sensory in nature. Chronic pain has gradually emerged as a distinct phenomenon in comparison with acute pain with the International Assessment Study of Pain, Association of Study of Pain, currently defining is as pain that lasts or occurs for longer than 3 months. You know now about definition, but now I won't say about types of pain. Acute pain is a protective mechanism that alerts the individual to a condition or experience that is immediately harmful to the body. Times is up to 3 months. And it's important that it's a symptom. We assessment on pain and with treatment on pain, and we know that it is a symptom because we need diagnosis why is a pain. Chronic pain extends beyond the period of healing and disrupts both sleep and normal activities of living over 3 months. And it is not a symptom. This is very difficult disease, very difficult for treatment. And we know that it's not symptom, but we have problem with disease. And here we have completely different treatment for chronic pain. It is not the same problem. Who measures, how to measure, what to measure? Assessment of pain. Pain is an individual and subjective experience modulated by physiological, psychological, and environmental factors such as previous events, culture, prognosis, coping strategies, fear, and anxiety. Therefore, most measures of pain are based on self-report. Self-report measures may be influenced by mood, sleep, disturbance, and medications. Assessment of acute pain is important because we need this for diagnosis, selecting on appropriate analgesic therapy, and assessment of acute pain is important for monitors the treatment. The first, we analyze site of pain, primary location, a description, where is the first place where is a pain. The second is important radiation and circumstances associated with pain, including details of trauma or surgical procedure. Also, of not always possible in acute setting, a complete pain history provides important diagnosis information that may help distinguish different underlying pain states such as nociceptive, somatic or visceral, or neuropathic pain. We may divide pain for nociceptive, reception pain, or no reception pain. And when pain reception pain, we have physiological, when we don't have injury tissue, and clinical. This is typical acute pain when we have injury tissue. No reception pain, it is when we don't have acute injury tissue, but because we don't have nociceptive problem, but we have, this is no reception pain is, for example, neuropathic pain or nociplastic pain. The International Associated Study of Pain definition of neuropathic pain is pain caused by a lesion or disease of the nerve system. This has been subdivided into central and peripheral neuropathic pain. Nociplastic pain is for which there is no physical case, but processing of sensitive information in central nerve system is disrupted. Nociplastic pain is pain that arises from the abnormal processing of pain signals without any clear evidence of tissue damage or discrete pathology involving the somatosensory system. The pathophysiological mechanism that cause these disorders primarily involve augmented sensory processing and diminished inhibitory pathways. And here you see now a picture about nociplastic, neuropathic, and nociceptive pain. And you see that the nociceptive pain, typical nociceptive pain, is somatic, like when we have bone fracture, metastasis on bone, muscle spasm, joint arthritis, post-operative pain when we have injury skin, and for example, burns. Visceral pain, nociceptive is mucosal injury, peptic ulcer, obstruction or capsular distension, kidney stones or gallstones, ischemia, for example, cardiac infarct, or tissue injury, cancer, or cirrhosis. Neuropathy, and look here that the treatment which we use for this nociceptive pain is analgesic, antidepressant, image guide injections, behavior interventions, non-steroidal anti-inflammatory drugs, neuromodulation, opioid, or exercise. When we talk about neuropathic pain, we have a case central and peripheral. Central is spinal cord injury, stroke, neurodegenerative like Parkinson's disease, autoimmune like multiple sclerosis, inflammatory like transverse myelitis. Peripheral is infection after HIV, acute herpes zoster, or post-herpetic neuralgia. Nerve compression, for example, carpal tunnel syndrome. Trauma, complex regional pain syndrome, metabolic amyloidosis, and ischemia, like peripheral vascular disease, diabetes, toxic after chemotherapy on acute immune, Guillain-Barré, or genetic. And treatment here is a anticonvulsant drug, an analgesic antidepressant, image-guided injections, behavior in the interventions, neuromodulation, and opioid. Nociplastic, it is cases like diffuse sensitization, like fibromyalgia, functional visceral pain, regional somatic sensation, threat nociception when we have problem with peripheral sensitization, central sensitization. This is a nociplastic pain is a very difficult for diagnosis because it's no specific. We have many symptoms, but without etiology. And here treatment is very difficult. Generally, we use anti-convulsations drugs like gabapentin or pregabalin, analgesic, antidepressant, behavior interventions, and exercise. And look here that there's a nociplastic pain, neuropathic pain, and nociceptive pain. This is different problems with different treatments. Character of pain. In the acute pain, predominates nociceptive pain, but neuropathic pain may also be present. Clinical circumstances associated with a high risk of nerve injury. For example, thoracic or chest wall procedures, amputations of hernia repairs. It is useful to draw the distinction between the different types of pain because the likely duration of the pain and the response to analgesic strategies may vary. Specific therapy target, for example, neuropathic pain, may be of benefit. Nociceptive pain. Somatic pain may be described as sharp, hot, stinging, is generally well localized and is associated with local and surrounding sensitivity. Visceral pain may be described as dull, cramping, or colicky, is often poorly localized and may be associated with sensitivity locally or in the area of referred pain, or with symptoms such as nausea, sweating, and cardiovascular changes. Neuropathic pain generally is character is burning, shooting, and stabbing, spontaneous or evoked unpleasant abnormal sensitization. We have here hyperalgesia, increased response to a normally painful stimuli, allodynia, pain due to a stimuli that does not normally evoke pain, such as light touch, or areas of hypoesthesia. Regional autonomic features, changes in color, temperature, and sweating, and phantom phenomena. Associated symptoms with pain: nausea, vomiting, sweating, and cardiovascular changes. We have visceral pain. It is when it's a problem with organs like pancreas or liver or kidney or gallbladder. And together with problem with these organs, when it's for example, inflammation or colic, stones, we have not only pain, but together with pain, we see symptoms like nausea, vomiting. And for example, when is the injury, heart injury, infarct, we have cardiovascular changes, for example, arrhythmia or hypertension, cardiac infarct. Intensity of pain. In the postoperative patients, this should include assessment static and dynamic on sitting, cough, or moving the affected part. Static measures may relate to the patient's ability to sleep. Generally, when we have NRS smaller like 4, it's a good treatment of pain. But when we check intensity of pain in dynamic, assessment of dynamic, this is, for example, on sitting, cough, or moving. This is simple test for mechanical hyperalgesia and determine whether analgesia is adequate for recovery of function. And here we should have a numerical rating scale smaller like 6. Aiming to reduce suffering and improve function rather than targeting zero pain is more in keeping with patients' expectations. In 2018, after opioid crisis in USA, Joint Commission implemented new and revised pain assessment and management standards. Patient engagement, multimodal therapy, and improving pain assessment by concentrating more on how pain affects patients' physical function. In the treatment of acute pain, pain assessment should be performed at appropriate intervals and described using scales that are consistent, valid, and reliable. Worsening pain should always prompt re-evaluation of the pain complaint and consideration of alternative treatment or evaluation in the context of other clinical situations. For example, cardiac infarct, transfusion incompatible blood component, or hemorrhage. For assessment of pain, intensity of pain, we use different scale. The first is a numeric pain intensity scale, when we have 0 to 10, and we ask patient, what kind of pain you feel when 0 is no pain and 10 is worst possible pain. And for example, when patients say 2, 1, 3, it's okay, because it's a no pain, mild pain, moderate pain. 4 is okay too. But when say 6, 7, 8, 9, 10 is a not good treatment. But in in a moment, because when we make provocation situation, for example, cough on moving, when we have moderate pain to 6 is a good treatment too. And depends what kind of, when we check intensity of pain, when we pain assessment at static, we should have 0 to 4. But when we assessment pain at dynamic, we should pain to 6, because this is because 0 pain is not normal. This is not our goal. For us is 4 in static, and dynamic 6. And of course we have visual analog scale, and we need for this line. And very often we use description pain intensity scale, descriptive pain intensity scale, like no pain, mild pain, moderate pain, severe pain. And you see that this the mild pain is around 2, moderate pain is 4, severe pain is 6, very severe pain is 8, 10 is worst possible pain. But when we check pain after general anesthesia, after operation, what do you think? Which scale is the best for check pain? Assessment of pain immediately after surgery can be more difficult and lead to greater interpretation variability in pain scores because of transient anesthetic-related cognitive impairment and decreases in visual acuity. A pain meter, Paula, which used 5 colored emoticon faces on the front of a roller and corresponding visual analog scale scores on the back, and allowed patients to move a slider to mark the pain they were experiencing, result in less variance than pain scores obtained from a standard visual analog scale. Uncontrollable or escalating pain should always trigger a reassessment of the diagnosis and consideration of alternatives treatment or other complications or presence of neuropathic pain. Assessment tools must focus on the patients as the authority on pain's existence and severity. Self-reports are not feasible when patient doesn't have the ability to verbally communicate. In some instances, it may not be possible to obtain reliable self-reports of pain. Patients with impaired consciousness or cognitive impairment, young children, elderly patients, or where there are failures of communication due to language difficulties, inability to understand the measures, unwillingness to cooperate, or severe anxiety. In these circumstances, other methods of pain assessment will be needed. There are not objective measures of pain, but associated factors such as hyperalgesia, behavioral responses, functional impairment, or physiological responses, like changes in heart rate, may provide additional information. We use many scales for this situation. For example, look here, we have many scales for children. Many for, it depends how old are these children, and we have different scale. HELPS is for children who have 1 to 7 years. But for for example, pain assessment in advanced dementia scale for elderly people. And we check breathing, negative vocalizations, facial expressions, body language, and consolability. Factors influencing the patient's satisfaction, belief concerning the case of pain, knowledge, expectations, and preference for pain management, expectations of outcome of pain treatment, reduction in pain required for patient satisfaction or to resume reasonable activities, typical coping response for stress or pain, including presence of anxiety or psychiatric disorders, for example, depression or psychosis, family, cultural expectations and beliefs about pain, stress, and post-operative course. Assessment of pain relief may be more sensitive to treatment effects than assessment of intensity pain. Pain has adverse clinical implications, but pain management is not an in itself. Opioid in post-operative analgesic regimens result in side effect. Opioid cannot be the only one painkillers in treatment. Optimal treatment of post-operative pain, acute pain, is multimodal analgesia. And now I want to say about creative of acute pain, pathophysiology creative of pain. Injury makes tissue damage, and this situation acts substance from damaged tissue, which activation of nociceptors, receptors of pain. They are sensitive to noxious chemical, mechanical, and thermal stimuli. Nociceptors are endings afferent fibers nerve, peripheral sensory organs, which detect noxious stimuli and their transduction chemical mediators to electrical signal, which are transformed to the dorsal horn of spinal cord after to the brain. We may divide 4 parts or creative of pain. First is transduction, transmission, the second. Third is modulation, and the last, fourth, is perception. It is important because we use for treatment of acute pain multimodal analgesia, and for every part we use typical drugs. For example, transduction. When a stimuli such as pressure damaged tissue is converted into a nerve signal. This occurs at the ends of sensory nerve cells whose terminals are sensitive to this type of action. These cells are known as nociceptors. Classes of nociceptors are activated by noxious stimuli, which include intense pressure, extreme temperatures, and damaging chemicals. Neuropeptides like substance P or bradykinin and prostaglandins released from the peripheral terminals also contribute to the recruitment of serum factors and inflammatory cells at the site of injury. Neurogenic edema. Injury produces chemical mediators like in infection or inflammation, and we see edema, effusion, and reddening. And non-steroidal anti-inflammation drugs modulate peripheral pain by reducing prostaglandins production and decrease inflammation. This part is transduction. This part inhibit non-steroidal anti-inflammation drugs and steroidal. Peripheral sensitization is most often produced by chemical signals of tissue damage, such as during infection, inflammation, or ischemia. Disruption of cells, degranulation of mast cells, secretions from inflammatory cells, or following induction of enzymes such as cyclooxygenase 2. A majority of chemical mediators act locally at nociceptor terminals by directly targeting ion channels or indirectly by activating intracellular signaling via calcium permeable channels or membrane receptors. In the presence of going stimuli, the excitability of nociceptors is increased. The threshold for activation is reduced, and the response to suprathreshold stimuli is enhanced. This increase in sensitivity within the area of injury due to peripheral mechanism is termed peripheral sensitization of primary hyperalgesia. The detection of noxious stimuli by peripheral sensory nerve endings, nociceptors, first requires the transduction of noxious stimuli into electrical activity and the conduction of these nociceptive signals in peripheral sensory nerves to the central nerve system. Nociceptive primary afferents are widely distributed throughout the body, skin, muscle, joints, viscera, meninges, and compromise both medium diameter lightly myelinated A delta fibers and small diameter slow conduction unmyelinated C fibers. And look here, this is schematic diagram or peripheral inflammatory mediators. We have damage, inflammation, plasma leakage, and many substances which activations nociceptive neuron. And after, we have transmission. This is situation when pain information go through nerve system to spinal cord. Radiation at the segmental level resulting in allodynia and secondary hyperalgesia. But after this, later. Transmission. The cell bodies of nociceptive afferents that innervate the trunk, limbs, and viscera are found in the dorsal root ganglion in spinal cord, while those innervating the head, oral cavity, or neck are in the trigeminal ganglia and project to the brainstem trigeminal nucleus. The central terminals C and A delta fibers convey information to nociceptive specific areas, dorsal horn, which encode both incous and noxious information. And now you see that spinal cord and central nervous system pathway stimuli are transmitted from pain receptors through sensory nerves into the dorsal root ganglion. The impulses enters the spinal cord, forms a synapse across the cord and rises to the spinal thalamic tract and to cortex. Transmission in spinal cord. Primary afferent terminals activate dorsal horn neurons by releasing two major classes of neurotransmitter. Glutamate as the primary transmitter and neuropeptides such as substance P, CGRP, galanin, and somatostatin as co-transmitters. The polarization of the primary afferent terminal results in glutamate release, which activates postsynaptic ionotropic alpha AMPA receptors and rapidly signals information relating to the location and intensity of noxious stimuli. In this normal mode, a high-intensity stimuli elicit brief localized pain, and the stimuli response relationship between afferent input and dorsal horn neuron output is predictable and reproducible. And this is situation on the left side. Incoming pain signals trigger the release of glutamate into the synaptic. In acute pain, glutamate activates AMPA receptors on the sodium and calcium channels. With prolonged activation, the polarization of the membrane changes. The magnesium plaque in the calcium channels and removed, and NMDA receptors are primed for glutamate activation. It's a free, it's a open. Calcium following into the cells activates protein kinase C, the enzyme needed for NOx oxide. NOx oxide stimulates the release of substance P, which binding to necrosis cells receptors in the dorsal horn membrane, triggers for gene expression, and promotes neural remodeling and hypersensitization. And this is right side. And this is much more complicated, and it is chronic pain because we have here remodeling in the spinal cord. Incoming pain signals trigger the release of glutamate into the synaptic. In acute pain, glutamate activation AMPA receptors. With prolonged activation, polarization, the membrane changes. The magnesium plaque in the calcium channels is removed, and NMDA receptors are primed for glutamate activation. Calcium following into the cells activation, and we have remodeling and hypersensitization. And tissue damage gives nociceptive stimulation. Intense and ongoing stimuli further increase the excitability of dorsal horn neurons in spinal cord, leading to neuroplastic changes, central sensitization. The intracellular changes associated with sensitization may also activate a number of transcription factors in dorsal horn with resultant neuroplastic changes, in gene and protein expression. It is central sensitization, like a scar, which is responsible for chronic pain because it's a pain memory. As a result of the increased excitability of central nociceptive neurons, their threshold for activation is reduced. Pain can occur in response to low intensity, previously non-painful stimuli, allodynia, and sensitivity spread beyond the area of tissue injury. It is secondary hyperalgesia. Wind up and secondary hyperalgesia may all contribute to central sensitization. Sensitization is the situation when normal pain response is much more pathology. We have hyperalgesia, heightened sense of pain to noxious stimuli, and allodynia, pain resulting from normally painless stimuli, for example, like a touch. Hypersensitivity increases sensitivity of the system involved in the pain processing. Hyperalgesia increased pain sensitivity to noxious stimuli. Allodynia, painful sensitization provoked by non-stimulation. The next part, which I won't say, is modulation. Many of pain signals are never reach consciousness because they are stopped by modulatory activity within the central nerve system. Neurotransmitters involved in these descending pathways include endogenous opiates, enkephalins, endorphins, and beta endorphins, serotonin, and norepinephrine. The afferent neurons, descending pathways, contribute to the modulation of pain transmission in the central nerve system. We have situation when pain from, for example, skin go through the spinal cord and after go to the area in brain, and after this is ascending way, and this situation activation descending way, which go down and inhibit pain process in rod ganglion in spinal cord. This is here is a schematic diagram summarizing the role of transmitters at the dorsal horn and which sites can be modulated. And you see here we have opioid here with the standing controls. Opioid like enkephalin, endorphin inhibit sensitization and transmission modulation in these receptors of the located in pain receptors in this in cells. Best understood is the standing pain modulatory circuit that projects to the spinal cord and changes the experiences of pain by directly or indirectly modulating, inhibiting or facilitating nociceptive traffic. The standing pathways contribute to the modulation of nociceptive transmission in the spinal cord via presynaptic actions on primary afferent fibers, postsynaptic actions on the projections neurons, or via effects on interneurons within the dorsal horn. These inhibitory mechanisms are activated endogenously through neurotransmitters such as endorphins, enkephalins, noradrenaline, norepinephrine, serotonin to reduce the excitatory responses to persistent C fiber activity. Similar mechanisms are the basis of many exogenous analgesic agents. This analgesia may be activated by either enhancing inhibition or by reducing excitatory transmission. For example, opioids, clonidine, antidepressant, local anesthetics, and ketamine. But about this later. Perception. Last part of creative pain is perception. Perception of pain is the awareness, typical and uncomfortable, associated with a specific area of the body. Perception of pain experience is influenced by social and environmental causes, cultural conditioning, past personal experiences. The pain threshold is the point at which a stimuli is perceived as pain. It does not vary significantly among healthy people or in the same person over time. Pain threshold. But the pain tolerance is expressed as duration of time or the intensity of pain that an individual will endure before initiation over pain responses. It is influenced by persons' cultural prescriptions, expectations, role behaviors, physical and mental health. And now I won't say why we should treatment of pain, acute pain. Inadequate acute pain management has substantial consequences for patients, reduced quality of life, significant impact on sleep, significantly impairment a range of other functions, including walking ability, general activity, social relationships, and mood. Delayed time to ambulation, greater potential for missed or shortened physiotherapy sessions, and longer hospital stays. Acute pain is risk for developing chronic pain. Post-operative pain is one from is associated injury and treatment triggers a complex hemodynamic, metabolic, and neurohumoral, immune as well as somatosensory response. Clinically, acute pain is commonly associated with actual tissue damage. This tissue damage may be due to the trauma or surgery. It is difficult to separate the complex array of potential individual or interacting triggers associated with pain from other aspects of the stress response observed clinically. However, some data have been obtained with experimental pain in the absence of injury. For example, electrical stimulation of the abdominal wall results in a painful experience. Visual analog scale is 8, and an associated hormonal metabolic response, which includes increased level of cortisol, catecholamines, and glucagon, and decrease in insulin sensitivity. A systemic review of the effect of experimental pain on the autonomic nervous system associated by heart rate variability determined that experimental pain increases baroreflex activity and decreases parasympathetic activity. Why we should treatment of pain, acute pain? Inadequate acute pain management has a substantial consequence for patients. Reduced quality of life, significant impact on sleep, significantly impaired a range of other functions, including walking ability, general activity, social relationships, and mood. Delayed time to ambulation, greater potential for missed or shortened physiotherapy sessions, and longer hospital stays. Acute pain is a risk for developing chronic pain. When we have injury response, postoperative pain is only one factor which activate cytokines and activate answer neuronal, humoral, metabolic, and immune. Pain is only one of the factors, including physiological and environmental factors that trigger complex intermediates, cytosine, neuronal, humoral, leading to the injury response. Even more indirect evidence of the effect of severe pain on the cardiovascular system comes from the response of the neuroendocrine system to severe acute pain. The response is multifactorial but includes cellular, immunological, and neuroendocrine consequences. The primary systems that respond to stress are the hypothalamic, pituitary, adrenal axis, and activation of the sympathetic nervous system by the adrenal glands, but result in the catecholamine secretion, catabolic hormone secretion, and increased oxygen demand. Free fat acids are increased during stress and also increase myocardial oxygen consumption. Thoracic epidural analgesia, attenuates pain, and reduce the catecholamine surge associated with acute pain. Increased sympathetic tone decrease epicardial blood flow by increasing resistance from alpha receptor stimulation. Severe pain activated the stress response, which increases perioperative cardiac morbidity. Excellent analgesia reduce this risk. And look, we have effect and consequence of pain. For a cardiovascular system, effects is increased sympathetic activity and consequence is increased heart rate, ionotropy, and blood pressure, resulting in increased myocardial oxygen demand. Clinical issues, risk of cardiac ischemia, particularly with pre-existing cardiac disease. When we talk about effects for a gastrointestinal system, increase sympathetic activity, reduce gastrointestinal motility, and clinical effect is ileus. Respiratory system effect of acute pain is ineffective cough and reduction in functional residual capacity. And clinical effect symptoms is atelectasis, ventilation perfusion mismatch, and hypoxemia. Metabolic effect is the activation of sympathetic and hormonal system. Consequences are inflammation, hyperglycemia, protein catabolism, increased free fatty acid levels, changes in water and electrolyte flux. Clinical effect is delayed wound healing, reduced immune function, diminished muscle strength, poor wound healing. And when we talk about, for example, a reduction in patient's movement, suppression of cellular and humoral immune function, thromboembolism, possible effect on tumor growth and metastasis. This is effect for acute pain. In the 7th decade of life, mortality after surgery increases regardless of preoperative risk factors. The loss of functional compensatory abilities with age leads to a decrease in perioperative stress tolerance. And now I want to say about pathophysiology pain. Injury makes tissue damage, and this situation acts substance from damage. Why we should treatment of pain, acute pain? In adequate acute pain management has a substantial consequence for patients. Reduced quality of life, significant impact of sleep, significantly impaired a range of other functions, including walking ability, general activity, social relationships, and mood. Delayed time to ambulation, greater potential for missed or shortened physiotherapy sessions, and longer hospital stays. Acute pain is risk for developing chronic pain. Acute pain and its associated injury and treatment triggers a complex hemodynamic, metabolic, neurohumoral, immune, as well as somatosensory response. Pain is only one of the factors, including physiological and environmental factors, that trigger complex intermediate cytosine neuronal humoral, leading to the injury response. Even more indirect evidence of the effect of severe pain on the cardiovascular system comes from the response of the neuroendocrine system to severe acute pain. The response is multifactorial, but includes cellular, immunological, and neuroendocrine consequences. The primary systems that respond to stress are the hypothalamic, pituitary adrenal axis, and activation of the sympathetic nervous system by the adrenal glands. Both result in catecholamine secretion, catabolic hormone secretion, and increased oxygen demand. Free fatty acids are increased during stress and also increase myocardial oxygen consumption. For example, thoracic epidural analgesia attenuates pain and reduces the catecholamine surge associated with acute pain. Increased sympathetic tone decreases epicardial blood flow by increasing resistance from alpha receptor stimulation. Severe pain activated the stress response, which increases perioperative cardiac morbidity. Excellent analgesia, good analgesia reduces this risk. And you see here effects of consequence, clinical consequence of pain. For example, for cardiovascular, effect is increased sympathetic activity and consequence in increased heart rate, ionotropy, and blood pressure, resulting in increased myocardial oxygen demand. And we have clinical effect like risk of cardiac ischemia, particularly with pre-existing cardiac disease. For gastrointestinal system, effect is increased sympathetic activation. We may have ileus, like a clinical effect. For respiratory system, effects is ineffective cough and reduction in functional residual capacity, inability to cough effectively and reduction in functional residual capacity. And effect is hypoxemia. Metabolic effects is activation of sympathetic and hormonal system, catecholamines, cortisol, endorphins, and we have consequences like inflammation, hyperglycemia, protein catabolism, increased free fatty acid levels, changes in water and electrolyte flux. And what kind of effect we have? The light wound healing, reduced immune function, diminished muscle strength, poor wound healing. And we should remember about elderly people, because in the seventh decade of life, mortality after surgery increases regardless of preoperative risk factors. The loss of functional compensatory abilities with age leads to a decrease in perioperative stress tolerance. And the last part of this lecture is a treatment of acute pain. And this information are from website postoperative pain and www.szpitalbezbolu.pl. For any given situation, there are numerous potential combinations and various multimodal methods that can prove effective depending on the type of surgery, individual clinical factors, and patients' preferences. Treatment of pain is adapted to surgical procedures, but generally, the principles of preoperative, intraoperative, and postoperative management are the same. For treatment of acute pain, we use method multimodal analgesia or balance analgesia. This is different classes of analgesic, different size of administration of the analgesic, different of the time, improve pain relief, decreases side effect. This is optimal combination regimens in individual surgical procedures. We use different methods for inhibit part of created pain. Look here, this is the first part creative of pain, pathophysiology pain. This is transduction. For inhibit this transduction, we inhibit by local anesthetics and anti-inflammatory drugs on steroid. Transmission, this is local anesthetics, and when we make blockade and with local anesthetics, but for this we use local anesthetics long acting. When we talk about sensitization modulation and transmission too, we use local anesthetics, opioids, and alpha-2 agonist. And for perception, generally we use for inhibit perception, opioids and alpha-2 agonist. We use multimodal analgesia, and these are two methods. Systemic, we give systemic drugs, and regional method. Multimodal analgesia, the induction of a sympathetic nerve block, direct clonidine, dexmedetomidine, alpha-2 adrenolytics, indirect lidocaine, anesthetics, volatile like sevofluran, calcium antagonist. The use of multimodal pharmacotherapy modulating nociception like ketamine, dexmedetomidine, lidocaine, magnesium, paracetamol, dexketoprofen, metamizole, peripheral nerve and central blocks. Peripheral nerve blocks are recommended as regional analgesia for surgeries in which the evidence shows their efficacy. It has been demonstrated that peripheral blocks are an effective component of multimodal analgesia for postoperative pain management in numerous surgical procedures, including thoracotomy, lower limb arthroplasty, shoulder surgeries, and caesarean section. Central blocks are recommended for postoperative analgesia after thoracic and abdominal surgeries, particularly in patients at high risk of cardiac and pulmonary complications and prolonged ileus. Because when we use central blockade for treatment of acute pain, we don't use generally opioid. And you know that side effect for opioid is ileus. When we don't use opioid, we don't have ileus. Epidural delivery of pain medication. In epidural analgesia, pain relievers are injected into the epidural space, which is within the spinal canal, but outside the spinal fluid. And we use for this catheter. Through this catheter, we give local anesthetics like bupivacaine and ropivacaine, and we may use for this opioid too. Local anesthetics. We have local anesthetics like lidocaine, but lidocaine is short-acting local anesthetics, and generally we don't use this drug for regional blockade. Lidocaine we use for treatment of pain, acute pain, but not for blockade, but for intravenous system analgesia treatment. We give lidocaine in vein, to vein. For local and for regional blockade, we use long-acting local anesthetics like bupivacaine, levobupivacaine, ropivacaine, prilocaine, mepivacaine. Analgesic effect by blockade of sodium channels in fibers, nerves, stopping excitation and conduction. We use systemic medications for acute pain management and intravenous ketamine, oral gabapentin, oral pregabalin, corticosteroids, NSAIDs, venlafaxine, nitrous oxide, amantadine, dextromethorphan, memantine, lidocaine, mexiletine. But generally, we may divide for analgesic. Analgesic is non-opioid drugs like paracetamol and opioid, and NSAIDs, and this is non-opioid drugs, and adjuvant. This is ketamine, gabapentin, pregabalin, corticosteroids, nitrous oxide, amantadine, venlafaxine. I say before that we use lidocaine but intravenous because inhibits granulocyte priming, which prevents the excessive release of pro-inflammatory cytokines and free radicals. The activity of mechanisms leading to development of neurogenic inflammation is diminished at the site of tissue damage, which decreases peripheral sensitization and primary hyperalgesia. Lidocaine inhibits secondary hyperalgesia, acting at the spinal cord level, inhibits synaptic conductions, thus reducing secondary hyperalgesia central sensitization. The synaptic conductions effects results from direct and indirect blocking of NMDA receptors and neurokinin receptors. The inhibition of muscarinic and glycine receptors enhance the activity of the descending cholinergic antinociceptive system. Opioid. Opioids are an important group of analgesic used for the management of acute and chronic pain syndromes. They are an effective tool in treating moderate and severe pain of various etiologies, provided that their use is supported by good knowledge of their mechanism of action and potential side effect. What make opioid? Opioid inhibition, transfusion, and modulation, and generally inhibit receptors and connection with białko C, G, and inhibit calcium channel. And we don't have problem in nerve because we have closed calcium channel. But we have a side effect after opioid, like nausea, vomiting, ileus or constipation, sedation and somnolence, pruritus, urinary retention, and respiratory events. They are analgesic effects, influence mood and behavior and affect the functioning at the respiratory, cardiovascular, gastrointestinal, neuroendocrine, and immune system. It should be remembered that the majority of opioids cause immunosuppression, which can result in an increased risk of post-operative infections. Opioid-induced hyperalgesia, opioid paradox, manifesting itself as an increasingly severe pain despite opioid dose escalation. Opioid-induced hyperalgesia, it is a situation when we give next dose opioid and patient feel pain and opioid doesn't act. And in this case, we should change this opioid, like a different, for example, morphine give oxycodone and tapentadol, and different drugs, for example, pregabalin and gabapentin. We don't like give opioid because people are afraid about side effect when we give opioid, and very often patients prefer fair pain relief but without side effect. Here we have different opioids. We have different opioids. The first is oxycodone, fentanyl, morphine. What kind of difference is between oxycodone and morphine or fentanyl? Fentanyl is generally we use in acute pain only during operation intravenous. We may use fentanyl for treatment of chronic pain when we use patch, but we don't use patch for treatment acute pain. When we talk about treatment of acute pain what kind of drug we use intravenous, subcutaneous way, or tablets. But patch, no. it is not good way for acute pain treatment. The next opioid which we have, this is nalbuphine, buprenorphine, tapentadol, tramadol, or methadone. You see that mechanism of action, nalbuphine is agonist receptors kappa, but antagonist receptor more. It is a very interesting situation because when we give nalbuphine, we make analgesia, we make sedation, but we don't afraid respiratory sedation, depression when we give dose for analgesia. And this is a good drugs, for example, for children. Tapentadol and tramadol is a very interesting drugs because there are agonist receptors more, but two inhibitor of noradrenaline reuptake, tapentadol, an inhibitor of noradrenaline and serotonin reuptake. Two ways to these drugs. This is a trigitation because when we think about opioids, what kind of good idea is good method for give opioid after operation? Good method is intravenous. What kind of dose? And we check how many patient needs, and we give every 5 minutes small dose opioid, and when we have analgesic dose, we this dose divide, and the next dose after the start, next dose is after 4 hours. This is a trigitation, but good idea when we think about method for opioid dose is patient control analgesia. It is a method when a patient control analgesia by button, special system. When a patient pushes of a button, and this system decreases any pain and anxiety you may feel, patient feels while waiting for medications. Doesn't feel anxiety while waiting for medications. The next drugs, which is a very popular in pain treatment, acute pain treatment, is a paracetamol. Paracetamol is analgesic and antipyretic, non-anti-inflammation drugs, and central anti-nociceptive effect, inhibition of central cyclooxygenases, activation of the endocannabinoid system, activation spinal serotonergic pathways. This is a good drugs, but very weak, and we should give paracetamol when we think about opioids because paracetamol reduces opioid consumption. And non-selective, non-steroidal anti-inflammatory drugs, analgesic, anti-inflammatory, antipyretic, inhibition of prostaglandin synthesis in peripheral tissues, inhibition of nitrous oxide synthase, inhibition of substance P, activation of the lipoxin system, activation of endogenous opiate like peptides, activation of supraspinal cholinergic pathways. It's a very, very good drugs and very strong and very popular when we talk about treatment of acute pain. But we should remember that this drug inhibition COX-1 and COX-2 substance, and when we use we have different generation non-inflammatory anti-inflammation drugs, non-steroidal anti-inflammation drugs. When we have inhibit cycloxy-1, this is a situation that we block at hemostasis for renal blood flow, platelet aggregation, and mucosa protection. And when we use selective COX-2, we inhibit renal functions, ulcer wound healing, vascular protection, bone metabolism, and female reproductive functions. And we should remember that when we use this is celecoxib, we inhibit selective COX-2, and we afraid about thrombosis and problem with stroke. And it is very good drugs for acute pain, but we afraid stroke after this. Adverse effects after non-steroidal anti-inflammation drugs is a kidney disorder, platelet dysfunction, bleeding, increased blood loss, peptic ulceration, and bronchospasm. And metamizole, this is a next drug, inhibits the synthesis of prostaglandins, COX-1 and COX-2 activity, but also by inhibiting substance P-induced nociception. But very important for metamizole is the relaxing smooth muscle effect results from the inhibition of adenosine reuptake in central nervous systems structures, and is a spasmolytic, and this is very good drugs. Metamizole displays a synergism of action with non-steroidal anti-inflammation drugs, paracetamol, on opioid analgesic. It is recommended for acute pain, including post-trauma pain, and is a relevant element of the combined treatment of pain. A recent cohort and observational studies, metamizole-induced agranulosis is rare, while its incidence is comparable to that induced by other non-steroidal analgesic. Adjuvant like magnesium sulfate is an antagonist of NMDA receptors present in the peripheral and central nervous system. The NMDA receptors are an important element of the glutamatergic system, whose main neurotransmitter is glutamic acid, glutamate. One of the functions of the glutamatergic system is the involvement in nociception. Magnesium ions exert anti-inflammatory effects by decreasing the plasma concentration interleukin 6 and TNF, tumor necrosis factor. The anti-inflammatory action can be involved in the reduction in the central sensitization. Magnesium sulfate added to intravenous morphine reduces the daily demand for morphine in the postoperative period. Alpha-2 receptors agonists exert their effect by stimulating alpha-2 receptors in the posterior horn of the spinal cord and supraspinally at the locus coeruleus. The perioperative use of an alpha-2 adrenergic receptors agonist, clonidine or dexmedetomidine, diminishes the intensity of pain in the post-operative period, enables reductions in opioid doses, and decreases the incidence of NUS. Gabapentin and pregabalin bind to a subunit of the alpha-2 presynaptic high voltage gate calcium channel, causing its inactivation. The above limits the axonal transport of active calcium channel to the synapse in the spinal cord and reduce their number in the neurotransmitter releasing apparatus, which results in a decreased intracellular inflow of calcium ions necessary to initiate the release of stimulating neurotransmitter like substance P from the presynaptic vesicles. And gabapentin pregabalin reduced neurotransmitter release decreases the excitation of neurons, which results in quick emergency of the effects inhibiting the development of central sensitization. These drugs are very good. This is anti-epilepsy drugs, generation 2. And these drugs are a first step for neuropathic pain treatment. Corticosteroids indirectly inhibit the activation of phospholipase by inducing the synthesis of lipocortin. The inhibition of phospholipase reduces the amount of substrate arachidonic acid available for cyclooxygenase and lipooxygenase, which in turn result in reduced synthesis of prostaglandins and leukotrienes, and finally produces anti-inflammatory effects. Ketamine is a very now popular drugs, but generally we use only for treatment, pain treatment, not for sedation, by inhibiting the activation of the NMDA receptor. Ketamine induces analgesia and prevents the development of chronic postoperative pain, whereas by activating adrenergic neurons and inhibiting synaptic reuptake of monoamines, is determines hemodynamic stability in the perioperative and post-trauma period. Cannabinoid doesn't exist in acute pain treatment. And detailed recommendation analgesic management in selected types of surgeons. Here is a situation, this is proposed for hernia repair operation, and here we have treatment for pain during operation and after operation. Please look here. For postoperative analgesia, we use base medication, conventional NSAIDs or COX-2 selective inhibitors. Use weak opioids when conventional NSAIDs COX-2 selective inhibitors are contraindicated, and combined with paracetamol. So that conventional NSAIDs with paracetamol when pain is more for at weak opioid and strong opioid when pain is much more 5. This is a recommendation for postoperative pain management for hemorrhoid surgery. And after operation, we give conventional NSAIDs or COX-2 selective inhibitors plus paracetamol, and oral strong opioid when we have moderate to high intensity pain, and when low to moderate intensity pain, we give oral weak opioid. This is a recommendation for treatment pain after cholecystectomy, laparoscopy cholecystectomy. Postoperative, we give conventional NSAIDs, COX-2 selective inhibitors with paracetamol and opioid rescue analgesia. And this is proposed for treatment of pain after thoracotomy or after hemicolectomy, for example. This is when we don't have contraindication, we make a central blockade like thoracic epidural, and with long-acting local anesthetics with strong opioid. And after 3-4 days, we stop give local anesthetics to thoracic epidural, and the next is a small dose opioid only for rescue. And generally we give multimodal rehabilitation and non-opioid drugs like COX-2 and NSAIDs with paracetamol drugs. And thank you very much, and for all, have a nice day.